It's a Saturday night at 2 a.m, get a call from your ST5, and she says that I have an 82-year-old patient in the emergency department who's got a tender red lump in the right groin.
It's a life-saving, it's one of those very limited life-saving operations that you can do and actually make a difference in someone's life.
It essentially depends on what they do with the scenario, because it's one of those kind of topics where they can do a whole variety of things. So
at this point, I'm concerned this is an incarcerated or strangulated femoral hernia with potential risk of having small bowel that may be ischemic and needs an emergency operation.
Hello again, Mo.
Hello.
Back for another episode of Scrubbing In.
Yes,
How have you been?
back from one. It's been well. This is our third year now, Scrubbing In.
Third year approaching it, yeah. And we've had some feedback, and we're now 1,000 subscribers. So thank you to everyone who's been subscribing.
Thank you very much.
Today we're going to talk about yet another important topic that is very commonly comes up in the FRCS, which is
emergency femoral hernia surgery.
Yeah, and in the context of the exam, almost always it will be an emergency, much like real life, I guess. What are the key things that we should know before we start going into the scenario?
So first of all, it's an important topic. It's not just for the exam, it's also important for your ability to do your job. It's a life-saving, it's one of those very limited life-saving operations that you can do and actually make a difference in someone's life. So in order for us to be able to answer the question, you need to be able to understand the anatomy of the femoral hernia, the anatomy of the femoral canal, the pitfalls and the kind of traps that can await you when you're doing this emergency operation in the middle of the night, that can make a difference between a smooth operation and not so smooth operation.
It essentially depends on what they do with the scenario, because it's one of those kind of topics where they can do a whole variety of things. So it could be more focused on the resuscitation and preoperative or perioperative care. It could be surgical technique. It could be controversies around it. It could be intraoperative kind of bowel resection and a whole bunch of other things. So yes, we'll talk through the anatomy. We'll talk through the resuscitating patient very briefly, because we've done that a lot and it's very similar to everything else. And we'll talk about some of the nuanced things regarding what to watch out for, and if they ask you side branch questions about differences in technique or mesh use, especially in the context of ischemic bowel.
Yes.
So let's start off with, you are the first year consultant on call over the weekend. It's a Saturday night at 2 a.m, get a call from your ST5, and she says that I have an 82-year-old patient in the emergency department who's got a tender red lump in the right groin. What's your approach to this patient?
Excellent. So at this point, I'm concerned this is an incarcerated or strangulated femoral hernia with potential risk of having small bowel that may be ischemic and needs an emergency operation. I will ask my junior colleague to prepare the patient for theatre while I get there to the hospital. So I'm asking them to make sure that they've had IV fluids, they've put a catheter in, they've drawn some emergency bloods, including a group and save. They've alerted the anesthetic team. They've also obtained an ECG. And at this point, it might be worth, if permitting renal functions, permitting the patient's relatively stable, to get an emergency CT scan. Right. That would delineate the contents of that.
Sure. So we'll talk a little bit about those things, but essentially to start off, it's exactly right. You've got to tell them what you think. I'm concerned that this is a serious situation, it could be strangulated bowel, but bearing in mind that you should have the flexibility that if it turns out to be something else as well, so that you're not too rigid. So what you want to start off with saying is the statement like you just said. I'm very concerned that this is a very common, very potentially very serious scenario. The instructions I would give whilst I'm making my way to the hospital would be to the emergency department would be to resuscitate, to assess and resuscitate the patient as per the CRIS protocol, or the sepsis 6, whatever the scenario is. Okay, and this would include giving oxygen investigations such as blood tests and ECG, antibiotics if there is an indication. And you would also want to say to mobilize your other resources, so that's your human resources, like speaking to the scrub team, the anaesthetist, critical care, whatever that may involve. Okay. With regards to CT, so they'll usually give you some feedback and say, okay, you're there, you saw the patient, and you would, again, we don't want to go back to saying what we always say every session, which is having taken a thorough history and examination, undertaken a history and examination, I would then do this. And you want to get through that relatively quickly so that you can get to the critical care critical decision-making step. Here, the question is CT versus no CT. So what are the arguments for and against?
So the arguments for is that you are getting a diagnosis, you're establishing the anatomy, you're also establishing the contents. It would make a difference in terms of planning the equipment that you need, staplers, and also planning aftercare for surgery, whether you bring out stomas, TPN, things like that. So that's the for it, and that would be my practice if the patient's stable enough and is not in extremis. The against is the impact on renal function, the delay to arranging to getting definitive treatment, which is actually the operation. And you should be able to express this thought process to the panel when you're answering the question, and take things into consideration based on what answers that they give you. So if they get back to you and tell you their EGFR is 12 or their systolic is 130, they can't, their systolic is 90, they can't really wait to go to the CT scan. They'll give you a prompt of some description
exactly, and that's
that you need to kind of answer towards.
Yeah, that's the key point. It's not being kind of fixated down on one line when they're telling you, giving you updated information that the situation is different. The key fours are that establishing diagnosis, seeing if there's something else, because just you've got a lump in the groin, but this could be a malignant lymph node, and there could be metastatic perforated bowel, bowel perforation secondary to metastases.
Hematoma, abscess, there's a number of things.
Absolutely. They will usually tell you, give you the indications that the patient's stable, and you can say things like, given the patient is hemodynamically and physiologically stable, I'd want a CT scan for these reasons, as long as you justify it. And they will then move you on. Okay, CT or no CT, fine. You've now got a diagnosis. They'll usually say a reducible lump, and shows that there is, or they may actually show you a CT scan where there's a knuckle of bowel coming through the femoral canal, and it's hypo-enhancing, and that's where the EGFR and everything else that you talked about is important, because it allows you to give contrast, and then you need to respond to that. So now I'm concerned that this is ischemic bowel and an incarcerated strangulated femoral hernia. Okay, we've already mobilized our team. They may ask you, then the station then may take a turn towards consent. What would you consent them for?
Wonderful. So again, it depends on the patient's own mental status. If their patient is capable of giving a consent form 1 by accepting and retaining information, being able to repeat it back and understand what's going on. So I will go ahead and consent them for an emergency laparotomy plus minus femoral hernia repair or other hernia repair, because you may find it's not when you go inside, with or without small bowel resection, bring out a stoma and proceed. The main benefit of this operation is to save their life, cut out any ischemic gut, and prevent further decline of their status from sepsis. The main risks obviously include injury to nearby structures you're operating against, the femoral vessels and other big vessels inside the abdomen. If you're taking out bowel, there's also a risk of anastomotic leak. If there is complications of a stoma, if you're bringing out a stoma, there's also a risk of returning to theatre because of these high-risk patients. You assess their risk of mortality using the NELA score, and you're also establishing the end-of-bed kind of clinical judgment on whether their mortality may be above 10% or less than 10%, depending also on their comorbidities.
And why is that important?
It's more important to, number one, get more support involved. So by that, I mean getting ITU and HDU.
So it's more than 10%,
activated.
more leaning towards having intensive care.
Intensive care, making sure senior colleagues are involved. So you're getting the anaesthetist on-call consultant to come and give you a hand, to be attending theatre. You're doing this operation yourself. You're not fobbing it off to the trainee, even though our experience is different. But
You mean at 3 o'clock in the morning?
At 3 o'clock in the morning, it's just you and another registrar.
Yeah, okay.
They went home, man. That's all. Yeah. So, but
it turned out to be lipoma, did it?
It turned out to be lipoma, yes. But it's important to also inform the patient and the relatives at that point, if you're able to, about all these things. Other risks with any major surgery include renal injury, lung injury, heart attacks, strokes, all of these things that you need to be involving with the patient. So things that are short-term, you're also dividing all of these things, as we do all the time, into kind of immediate, intraoperative, early post-operative, and late post-operative.
So there's various ways of doing the consent thing. The first thing, like you say, it's important to establish whether they have capacity. So that's, especially if you're given a very frail elderly patient, in the blurb that you get, in the scenario. That's a very key point, because then a large chunk of the scenario might actually just fixate on that. That might be your scenario, around consent, doing an MCA, doing a mental capacity assessment, and consent 4 versus consent 1. Assuming that they are have capacity, you can do consent form 1, and yes, you can do it short term, medium, or long term. I tend to divide it up into kind of general risks versus
Operation specific, yes.
Specific, yeah. So anesthetic infection, bleeding, DVT in the legs, pulmonary embolism, and death is one that you've got to consent for as well. That's kind of pretty much universal to most emergency operations. And then you're going to be talking about things that are specific, that's bowel injury, bowel resection, anastomosis, leak, return to theatre. If you're going to use a mesh, possible mesh infection, and of course in hernia repairs, you've got to say recurrence as well. Okay, good. So now they're going to say, okay, the patient's been consented, whether it's consent for 1 or 4, you're in theatre, having adequately prepped the patient in a supine position, undertaking the WHO checklist. What are you going to do next in terms of the operation?
Wonderful. So my approach to these is a high approach, also known as a McEvedy. And the reasons I take that approach is that it allows me to inspect intraperitoneal contents that have been sucked into the hernia and probably need addressing. In this scenario, we're thinking there's dead small bowel. And it also allows me access to the femoral hernia to repair it adequately.
Very good.
In a big incision and in a comfortable for me, and makes it a quicker operation as well.
Yeah, fair enough. So before we just proceed on that, because there's got a lot of discussion and nervousness about laparoscopic versus open first of all, and then which one of the 3 incisions that you do. So we'll just talk through them because it's quite a key point. Laparoscopy in real life, I think we've both done laparoscopic ones, tap hernia repair, and it wouldn't be a wrong thing to say, but you've got to be very confident that you can back that up and that you've done it before, because it's supposed to have you done this before, especially if they give you a scenario where the bowel loops are all dilated because having the capnoperitoneum and getting into the abdomen safely. So I think for the purpose of the examination, probably best staying away from that and going more with open is probably the surest thing. So we'll assume it's going to be open. And there's 3 incisions, okay? You've got the McEvedy, which is high up, whether you do it vertical or transverse, and we'll talk a little bit about that in a while. Then you have the second one, which is Litharsin, which is the one that goes transinguinal. That I don't think there's many takers for that one. And then you've got the low one, so a very high one, McEvedy, and a low one, which is Lockwood. Lockwood's the one that I think a lot of people, where you make a cut essentially over the lump. Right
to the top of the canal, and that's usually reserved for semi-elective patients. You're not relying on, it's very difficult to do a small bowel resection through that.
Yeah, absolutely. And so the Lockwood one is a low one over the lump. That's going to give you, you're right over it, so it's not a terribly painful incision, but the downside is you're quite limited as how to do it in terms of access, especially if you have to remove bowel. It's not one we would recommend for emergency. Litharsin, I don't have much experience with, to be honest. It's something that we've read about in books, but you go essentially transinguinal. I think unless you can describe that one pretty confidently, I'd stay away. McEvedy is the one that they want you to say.
The one to talk about.
McEvedy incision can be either
vertical or horizontal.
Or horizontal, transverse, yeah.
Transverse.
So I think, and I've seen people do both. So which one would you do, and just describe it to us what that is?
Okay, so we're electing to go for an open McEvedy approach. My incision in these is usually transverse, and my reason for that is that they're usually better in terms of pain.
Okay.
And it heals the same way as an inguinal.
Perfectly reasonable, yeah. So we'll go with transverse McEvedy.
So the way I describe it is that you're doing a standard transverse incision like you're doing an open inguinal hernia repair, and that is where the resemblance ends. So you're going like 2 fingers above the pubic tubercle, transverse approach, ending towards the midline medially, and just opposite the anterior superior iliac spine laterally.
Yeah. So there's a slight difference in the incision in the sense that if you did an elective open inguinal hernia repair, you're going to go 2 to 3 centimeters above the inguinal ligament, and you're going to do it oblique.
Exactly.
With the McEvedy, it's more transverse, it's more flat, but it's pretty much around the same area that you'd make it. And you're going essentially from the ACES, it's not all the way, but near the ACES.
Those are like the boundaries if you want to extend it.
Yeah.
But you're aiming for that.
So you've made your decision, it's skin, subcutaneous fat,
superficial fascia.
Yeah.
And then this is the point where you want to make sure you're not accessing the inguinal. canal, and you're doing this for on purpose for once.
Unlike an elective repair.
Unlike an elective, where you find yourself.
Too high, yeah.
If you found the kidney, you've gone too far. So you're going away from the inguinal canal.
So you're down to the external oblique.
Down the external oblique, above the inguinal canal. You're splitting the external oblique as you
Like you would
traditionally.
you open it up, but you don't go into the inguinal canal.
You're going above the inguinal canal.
And you've got muscle.
And you're splitting the muscle. And you're splitting the muscle along the muscle fibers, so there's no bleeding, there's no ripping. And then you're until reaching all the way to the peritoneum. Now this is the part where you make sure you've split enough muscle so that your hands are comfortably, at least one hand can go inside to be able to retract. And also, so you need to split the muscle accordingly. And you're operating outside the peritoneal plane, so you need to be able to slide over the peritoneum inferiorly, so you're able to reach the femoral vessels and behind the inguinal canal. And once you've created that plane, then you open the peritoneum, and you want to do, and I'm going to refer to Professor Modi here, a full peritoneal survey as much as you can through the peritoneum.
Okay, just to recap, it's an incision that's about 2 to 3 centimeters above the inguinal ligament in a transverse fashion. You can't do vertical, but most people do transverse from ACIS to the midline, okay, towards pubis. You're going through skin, subcutaneous fat, carpus, and you're on external oblique, and you open external oblique, and you're going slightly above it into the muscle layer, which you're going to split.
Yes.
But you're not going to go all the way through the peritoneum. You're going to create a little pocket underneath. Okay, so that, like you say, you can skirt underneath the muscle and go towards
the hernia from outside the sac.
Then once you've got that pocket, so you're essentially creating a pocket above like you would do in a TEP, I guess,
Exactly.
above the peritoneum, but just behind the muscle. And you would then, given that's an emergency one, you're still going to open the peritoneum because you need to see the bowel, right?
Mm-hmm.
Okay, so here, this is where they're going to give you some direction in terms of the scenario. They're going to say, okay, you examine the bowel, loops have dilated, you reduce it, you've got full relaxation on board from the anaesthetic colleagues, and you pull back the small bowel, and there's a knuckle of dead bowel. What do you do?
You proceed to a traditional small bowel resection, depending on the size. If it's literally a small knuckle, you can do a wedge resection and do a hand-sewn anastomosis. If it's a longer segment of bowel, you can go do a Barcelona technique with staplers.
Side to side, yeah.
Side
so
to side.
Ultimately, do what you usually do.
What you usually do.
do.
But the determinant here is whether there was perforation and contamination of small bowel contents or not.
And that's your kind of abdominal kind of investigation, full survey, okay.
And then that will then allow you to have a discussion, if there's time, with the examiners, whether or not you're going to use mesh later on, but we'll talk about that in a second.
Yeah.
So you've done the traditional small bowel resection. There's no other contamination that you've picked up. We've run the small bowel enough before and after the hernia, and there was no other abnormalities. You're going to close the peritoneum. And then because you mobilized the peritoneum off the muscle before, you're going to push that out of the way from your field, so you're able to see and operate on the femoral canal. I think this is probably a good time to describe the femoral canal boundaries.
It's a perfect time. It's almost like you're planning.
It's almost like we planned it. It's almost like we discussed it. Yeah, I know.
The femoral canal. So they may then pause or take you to a side of asking the anatomy, what they may ask you earlier on. What are the boundaries of the femoral canal? So anterior, posterior, medial, lateral.
Excellent.
Thanks. I don't think I get those fourth. Anterior is the...
Isn't this the podcast where we decide 5 divided by 1 is 1? Isn't that right?
Yeah, we're still looking for the answer to that one.
So anything that was under 5 is a bit tricky.
That's our baseline, yeah.
So anteriorly is the inguinal ligament.
Is the inguinal ligament. Posteriorly.
Posteriorly is the pectineal ligament.
P for posterior, pectineal. Medially.
Medially is your femoral vein.
No.
Sorry, medially is your lacunar ligament. Laterally is your femoral vein. I was going to do that.
Intentional error there, just to recap. Anteriorly is the
anterior inguinal ligament. Posteriorly is the pectineal ligament. Laterally is the femoral vein. Medially is the lacunar ligament.
And one of the reasons that the femoral canal organs are susceptible of being incarcerated in is because it's a short canal.
Sharp edge of the...
1 to 2 centimeters. You've got a sharp-ish edge of a lacunar ligament that's not expansile. And the same with the femoral vein. So you've got a very narrow, small pocket where something can be pushed through, causing venous congestion. Then there's no real room to expand. So whereas in inguinal there is much more room because you're not as
Things are likely to engorge, strangulate rather than retract.
exactly. So that's the boundaries. Okay, you've retracted the small bowel. It's healthy, not healthy. You've done a resection. If it's not healthy, fine. Then we're down to what do we do? Mesh or no mesh? That's another key point.
I don't use mesh, but you can offer it as an option in the exam. So you can say I can fashion a prosthetic mesh plug, or you use any of the commercially available ones, and basically you're stitching that plug into a couple of two sutures, 2 bites into the inguinal ligament and the pectineal ligament to narrow the canal, not completely obliterate it.
Yeah. Sometimes they may ask you a scenario by the bowel's really stuck. It's not coming through. What can you do to release it? What do you do?
So I was thinking about that. So you can start by dividing the lacunar ligament medially.
Medially,
if you can
medial
reach,
safe.
if you
Laterally
can
is not.
lateral, you're dividing the femoral vein. Do not go there. That's not a good idea. And if still you can't get enough space, you can also divide the inguinal
Yeah,
ligament.
so you can split it
split a couple
anteriorly
of-
or split it medially. They're the two safe spots. Obviously, posteriorly, you're not going to have access to it, or it's not going to be terribly helpful. And laterally is a no-go. Okay, so you're going to divide the lacunar ligament or the inguinal ligament. Okay, with regards to mesh, if you've got ischemic bowel, but there's no contamination, so there's no bowel content, and there's no free kind of
There's no
contamination otherwise.
ischemic liquid that comes out. There's no tissue scarring. And
Yeah,
things like
you
that.
can. So just because the bowel is ischemic, it's not. Never going to use a mesh. You can use a mesh. The only time why you wouldn't, you absolutely would avoid using it, is if there is true enteric content or bowel content or contamination. Okay, some people use a mesh, some people don't, and you could form a plug, right? So you can roll it up into kind of like a cone shaped and stitch it. Again, if you're stitching, be mindful. Say something along the lines of stitching it to the lacunar ligament medially, and you're going to be or the inguinal ligament. You're not going to be stitching laterally. And the idea is that you reduce and fill the space, not completely obliterate it. Fine. So you've done that, and then your closure.
We've narrowed down the inguinal femoral canal.
Whether it's sutures or mesh.
Sutures or mesh.
Yep.
You've split the muscle, so you don't really need to close that. You've
Just
closed the peritoneum already,
close the peritoneum.
so you're closing the external oblique upon neurosis as you would. You can use Vicryl if you want. Treat it like a pediatric appendix, or you can use PDS in traditional fashion.
Yeah.
Discuss with your anaesthetist. You might want to put local anesthetic wound catheters in there.
Yeah, so regional blocks. Or
Regional blocks.
There are other things that makes you look like you're polished and you're thinking about
I've done this before.
Yeah.
And then staplers, monochrome, depends on how confident you are.
Yeah.
And that's it. Post-operative, if it's a frail patient, they've been obstructed for a while, usually is the scenario. It's likely that they're going to go into ileus anyway.
Yeah.
So hopefully you've discussed with the anaesthetist that you're going to put a central line in for TPN. So we're expecting nutritional support for at least a week.
The things we need to, and it depends on the scenario. So the things that you need to address is that, as always, is where's the patient going to go to? So is this
Exactly.
Level 2, level 3? Is it the ward, depending on the scenario? So that's a discussion you're going to have with the anaesthetist. Okay. So it's one, where they're going to go, and two, it's going to be the general post-operative care. So that's low molecular weight heparin, TED stockings. If antibiotics are indicated, you continue antibiotics, early mobilization, and then it's more the GI specific stuff. If the patient is obstructed, you're going to say NG tube, deal with ileus.
I think everyone's going to have an NG tube in an
Yeah.
emergency scenario. Quite early, as I said, where they're ending. If we're, again, following the beginning of the scenario where I said their mortality is probably more than 10%, then ITU, HDU discussions and certainly admission is something that needs to be considered. Low molecular weight heparin, this is not a bleeding patient, so they can start VTE prophylaxis straight away.
Yeah.
Antibiotics, definitely. And then physiotherapy, the usual chest physiotherapy, things like that. In terms of nutrition, we're thinking they might head towards ileus, so we're gearing them up towards dietitian review and potential use of the TPN.
Excellent. So you're going to think of, and you're going to say something along the lines of the post-operative care strategy would be centered around whether they're going to go to level 2, level 3, level 1, providing nutritional support, DVT prophylaxis, antibiotics, early mobilization, and early physiotherapy, as part of that mobilization. And you're going to say something along the lines of by working in an MDT approach, you're going to be working with our physiotherapy colleagues, the nutritional support team, dietitians, etc. And that's what gives you those kind of higher level order thinking marks. I think that is pretty much.
I think that covers it.
Is there anything that you can think of that would be slightly curveball that could throw at you? I think most of the things are about the anatomy, or they may flip. It was like, well, what if the patient wasn't stable when you say on a CT scan, and then you have to switch gears, and it's important that you're flexible going down both avenues. Do mention, Nella, working with your colleagues. These are in all scenarios, because these are the things that will get you those extra marks.
I think if you're the one final point we emphasized that you probably do open these operations.
What they may ask about.
But if they do ask you about laparoscopic, I think the cons here is this patient's unstable. There's slightly a time factor as well, because laparoscopic might take a bit longer. We're not all Mr. Ascari. We can do these things in 35 minutes.
With a lipoma.
With what? And the pros, however, are that you can see what you're doing. You can assess the bowel in the same go. If the bowel is healthy, then there's no urge to rush.
And more elderly patients, the recovery isn't it? You're going to have quite small incisions.
You've got better recovery, and you're treating the whole area, so there's less likely of femoral hernia. Less likely of recurrence from a femoral hernia or an inguinal hernia as well.
And you could always still do a tap setup to do a laparoscopic procedure if you know how to do it. And again, I wouldn't start off with that. That's only for extra marks. They're pushing you towards it. And you can even, if you have to resect bowel, you can bring it out into the midline port and do your bowel resection, put it back in, using one of those kind of, by extending the incision a little bit and using one of those capped
wound retractors.
Yeah, wound retractors.
We can use their name and then we can ask them for money. What do you think? Next time.
Yeah, other alternative products are also out there.
I think that's it. Well done.
Thank you very much.
Thank you.